And at that time, people used to always think that pediatric endocrinology is one branch, which is basically very, very rare, dealing with rare, complicated disorder, which require cumbersome evaluation and expensive treatment. This was a common thing. Everybody used to say, what will pediatric endocrinology do? Nothing much to be done at this there. But when we started seeing patients, we were shocked by the way they were being managed. And this is one case with Dr. Rashmi and both of us managed. It was a very short child, diagnosed in 10 years with severe anemia, presented for the first time. And then at that point of time, there was a short stature and was given a blood transfusion, diagnosed as a case of celiac disease, but unfortunately had developed HIV because of the blood transfusion which happened in that scenario. So this was an unfortunate scenario, a case which should have been diagnosed at the right time and should have been managed in that perspective or missed in that scenario. So we thought, what are the problem? Is it a problem of awareness, accessibility, or affordability? Now everybody says it is always a problem of cost. So people say cost is a major problem. But what is the truth is actually the elephant of the house is awareness. If you don't know when should you go, where should you go, how you should be managed, it is difficult. Once you go, direction is there, people will help you. People will help the patient will help themselves, but most important is awareness. So from there, we started our program, and 2012, we had the first PPEC, and a lot of people here, including all the seniors, Dr. Subrato, Dr. Rishi, everybody was part of that program. And since then, we have conducted huge number of programs across the region in the country. But unfortunately, how many physical programs one can do, that is a limit to that. So we started the advanced programs as well. So we moved forward from there to internet media, because now internet is available. So we started on YouTube around 7 years ago. And from there, we moved forward towards a structured program, both on-site as well as online. And now we have got the application and other things which are happening. We have e-learning program, which has got huge number of subscribers, and all of you would have accessed that. This would be something to go forward. But problem with YouTube is that you can see one video and then you forget about it. So if you want to have a systematic learning, we started off with this program of Medi classes 4 years ago, in which we now have a fellowship program and a diploma program. A lot of programs are there. A lot of people are part of that program as well. Now, we also run regular postgraduate fellow classes, and the publications and applications are there. Applications are going to make very easy day-to-day management in that regards. The often problem which still remains is that the number of pediatric endocrinologists in the country may be around 100, and 100 may be an overrating, exaggeration. Cases are thousands. So what do we need to do? There needs to be a bridge between cases, pediatricians with special interest, and then more pediatric endocrinologists. This is what we are looking at. For that, now we are trying to come up with a solution, which hopefully will come up in the next 2 to 3 months, which will help you out using a personalized, intelligent EMR. So what it will do is that based upon your particular problem, so if a child has short stature, once you say short stature, specific questions will come with regards to history, examination. This will be there for all conditions. So precocious puberty, delayed puberty, DSD, whatever, 40 conditions we are developing these protocols. You just have to enter these data. Once you enter, you will ask specific questions in examination. So for a delayed puberty, it will ask anosmia. For precocious puberty, it will ask about headache. So different questions will come. Once you answer those questions, put basic data while you are examining the patient. This is looking very benign, simple. You're just putting. But what is, and you can simultaneously assess bone age there. So it looks very simple, you're doing that. But what is happening is that behind the scene, algorithms are running, which are then telling you this is the diagnosis. This is the investigations required. This is the likely treatment. And then you will get a lot of output. And you can then export it in the form of a proper, it will give you like a proper history has been taken. You will get results, interpretation. This is a work in progress. A lot of intelligent algorithms required. It will take time, but this is the way forward. So this will allow everywhere across the country to have a state-of-the-art, quality assured sort of a management, and then there could be connections with clinics as well. So this is something which we are working in that direction. Last 3 days, we had very intense program in the Regency Center for Diabetes, Endocrinology and Research. Over 30 people from across the country had come, and it was a very good interaction with over 300 cases, in which a lot of interactive discussions.
All are the cases representing the importance of halting the puberty, whether it is early puberty or whether it is rapidly progressive puberty. So we know the HPG axis, it all starts with the brain. Hypothalamus will secrete GnRH, will act on the pituitary, gonadotropes, which will secrete LH they will act on gonad to produce the sex steroids. And this sex steroids will drive the puberty, estradiol in female and testosterone in male. But for the bone fusion in both genders, estrogen or estradiol is the hormone. Even in male, testosterone is converted to estradiol, and then this estradiol is responsible for the fusion of the bones. So criteria of the precocity, as discussed earlier, that in female, thelarche before 8 years and menarche before 9.5 years. And in male, any development either pubarche or testicular volume more than 4 ml before 9 years of age is suggestive of precocious puberty. So how do we diagnose the central precocious puberty? Because we are dealing with the GnRH, we will be focusing on central precocious puberty only. So clinical criteria includes it should be concordant puberty like thelarche followed by pubarche followed by menarche. Height spurt is again a clinical clue to the central precocious puberty. Now LH, basal LH is the newer guideline suggesting that now we have a more role of unstimulated LH, that is basal LH. And now they say that basal LH more than 0.2. So any detectable LH is suggestive of onset of puberty. Plus, we can do stimulation tests if we are not matching the LH with the clinical parameters. Suppose if we have more pubertal features and still LH is low, and we are thinking of a properly central precocious puberty, then we can do GnRH stimulation test. Otherwise, the newer guidelines which were published in 2019, in which Dr. Anurag sir represented our ISPE, suggests clearly that nowadays basal LH of more than 0.2 you can take as origin or the onset of puberty. Of course, there is a role of ultrasound, but that will only supportive role like ovarian volume of more than 2 ml or uterine length of more than 3.5 mm again suggestive of estrogen exposure and the onset of the puberty. Now, why do we need to treat the precocious puberty? Because there might be some multi-system affection which is driving the puberty, like tumor and all. So definitely we would like to treat that primary etiology which can affect the multiple system and not the only pubertal part. Of course, height is a major issue because we know that the high estrogen will initially lead to growth spurt followed by the early fusion. So ultimately final height will be low. And the psychological issues regarding the handling menstrual period at a very early age when all the school friends don't get menarche. So treatment protocol includes GnRH. Now we are more focusing on depot preparation. So as compared to the monthly GnRH, now we are more preferring 12 weekly or maybe 24 weekly or maybe yearly depot subcutaneous infusion, the subcutaneous implant which is there. And any girl who has the feature of puberty less than 7 years and any boy who has the feature of puberty less than 9 years, at first visit, if they are of SMR3, then directly we can straight away start the GnRH analog on first visit. That is the new guidelines. If boy is more than 9 years and girl is more than 7 years with SMR stage 2, they have just onset of puberty, then they say then you can wait for 4 to 6 months to see the progress of puberty because these all might be slowly progressive puberty. So there is no need for hormonal evaluation after 7 and 9 years of age in girls and boys. You can definitely wait, but if they are smaller than that, they are younger than that, then definitely they warrant the investigation at first visit and preferably treatment at the first visit. If there is systemic disorder which is driving the puberty like hypothyroidism and any other thing, then no hormonal treatment is needed. We should start the specific treatment for the disorder. Now we have triptorelin available, which can be given monthly, that is 3.75 milligram intramuscular. But most commonly used is the leuprolide because it is freely available. In my city, we don't have triptorelin, so I am using leuprolide. Leuprolide can be given monthly or 3 monthly. It comes in 3 concentration in India: 3.75, 11.25, and 22.5. So either we can give 3.75 monthly or every 12 weekly, either 11.25 or 22.5 milligram. Or hysterin, which comes as 50 milligram of implant. You need a minor surgical procedure to put the hysterin implant, but in India, this implant is not available. In foreign, they are using because they just have to do once a year procedure. It will gradually release 60 microgram of hysterin per day. and then we will have puberty which is suppressed. So nowadays, this is the recent guidelines. Nowadays is initially when I was in fellowship, we used to give deep intramuscular because this this injection clog soon after dissolve. But nowadays they are more preferring subcutaneous. So now you can give even subcutaneous. It will cause less pain. So initial swelling will be there, but it will quickly get absorbed. So nowadays they recommend more subcutaneous injection. Now they said that they prefer more of a depot, more of a 3 monthly, maybe 24 weekly, which might come in the future. And there is no weight-based dosing. Earlier, when we were studying, we used to give less than 30 kg and more than 30 kg. But nowadays, they say that you start with fixed dose, say maybe 11.25 milligram of leuprolide, and then you monitor for the pubertal suppression clinical features, and then you can readjust the dose accordingly. So no weight-based dosing for this recent guideline, and of course, citrulline is not available in India. So what will this GnRH do? Breast size will be remaining stable, or they might regress the gland part. Of course, fat part will be there. So breast will not be going flat at all. Pubic hair and axillary hairs, because they are mediated by the adrenal gland, they will continue to grow. So many times it happens that the parents complain that pubic and axillary hairs are growing, but we should reassure them this will not affect the height potential of the child. Menses stops usually after 2 months of therapy. The girl can have breakthrough bleeding maybe once or twice after giving first injection, but definitely after giving second injection, menses should be stopped. If girl is still experiencing menstrual bleeding, then definitely her puberty is not suppressed, and we should look into the revising the dose of the GnRH analog. And hormonal suppression will be achieved after few months, after 4 to 6 months. So many times it happens that we tend to do LH after giving injection after first and second injection, but nowadays they don't recommend biochemical monitoring of doing LH maybe 2 hours after injections, because hormonal suppression will take time. Before that, growth velocity, breast size and all are good clinical markers which can be used to monitor the therapy. What are the adverse effects after giving first dose? If the endometrial thickness is more than 5 mm, girl can have withdrawal bleeding for maybe once or twice. She may experience hot flushes, and seizures has been noted in CP child, whom because CP child, this GnRH analog will decrease the threshold for conversions. Weight gain has been noted, but still, that is the normal weight gain of the pubertal spurt and all. No specific weight gain is associated with GnRH injection. Future risk of PCOD, it is not proven, and pituitary apoplexy can be there if there is GnRH hyperplasia and we give GnRH analog. So there will be pituitary apoplexy, and we should be managing it as an emergency. How to monitor therapy? Clinically, we should be calling them 3 months. We should be checking for breast changes, bone age, and growth velocity. Biochemical is a very limited role, but if at all you want to prove that their puberty is suppressed, post GnRH, post 2 hours of LH should be less than 4, and this you call as adequate suppression. Stop. When do you want to stop? So there is no fixed parameter. It depends on patient to patient basis. But overall, 12.5 years of bone age in girls and 14 years of bone age in boys is the clinical parameter, or we can say radiological parameter when we stop the GnRH. Other uses, particularly, they are officially recommended in transgender. In transgender male who have been converted from female to male, we can give this GnRH analog so that they can suppress the estrogen, and by giving 1 to 2 testosterone, they will have normal effect of the testosterone. But in female, transgender female, the testo will not be suppressed for initial period, so they might need for longer period this GnRH. But other, along with the growth hormone, because in some desperate families, in desperate some kids, they want to grow and they have achieved advanced pubertal progression, in which some centers are giving GnRH analog to hold the puberty along with the growth hormone, though they are growth hormone sufficient. But again, this is a controversial thing, because in a way we are suppressing the growth spurt by suppressing the gonadotropins and sex hormone, and we are giving growth hormone in other way. So the height gain is controversial. So this is not a routine practice, and it is not recommended in fertility suppression, SGA, autism, or any psychological issues. So apart from this puberty, only transgender is the only indication in which we can use the GnRH analog. So learning the point for this guideline is no weight based, more of a depot use. more of a subcutaneous route, use of unstimulated LH in the diagnosis, and less hormonal monitoring and more of a biochemical, more of a clinical as well as radiological monitoring.